So we're going to dive even deeper now. So we've gone through and we've reached the point where we say, okay, I need treatment. So we're going to welcome Dr. Joseph Flynn and Dr. Anthony Amato. I have the privilege to know both of them for several years to discuss frontline therapy options and also measuring the response, including a hot new topic that Dr. Amato has done a ton of research on, which is MRD, or measurable or minimal residual disease. We'll start with Joe Flynn. Joe is the Chief Administrative Officer at Norton Medical Group and Physician-in-Chief at the North Cancer Institute in Norton Healthcare in Louisville, Kentucky, and has both a professional and family interest in CLL. Just in way of introduction, Dr. Flynn, do you want to tell us a little bit about how you got involved personally in CLL research?
Sure, I'd be delighted. First, thank you very much for the chance to be here. This is really, I think, when you look at CLL Society, all you're doing, the comments, smart patients get great care or get smart care. I think nothing's truer. My story started back in the late 1980s when my mom was diagnosed with CLL. And at the time, like many people probably listening today, she was told, congratulations, you have the good cancer. And 11 months later, she was gone. And at that time, we had no ability to become smart patients or smart family members, because really, I think everyone knows this impacts everybody. At that point, I made the commitment I was going to dedicate my professional life towards this disease and trying to help patients and really trying to help family members who were going through it, because we were just lost. And there was no such thing as CLL Society. There's no groups to look at the patients and their families and what they go through, and how do you deal with patients. And at the time, she had the choice of one treatment, and we could have any treatment we wanted as long as it was that one. And as I noted, she died. And I think for me, it's been such a hopeful journey to see where I came from originally, where my family. Even back to Brian, when you and I met many years ago, to where we are now, it's utterly inspiring from my vantage point. I think there's so many things we know now we didn't know then, and there's treatment options we have now that we couldn't even imagined back then. So I'm grateful for the chance to be here.
Thank you for sharing that little bit of a personal story. So let me ask you this. You've got a patient in front of you. You've both decided that it's time for treatment. What do you say? How do you work that out with your patient in terms, because today there are so many treatment options. So kind of what factors are you looking into? How are you deciding what that best treatment is? And I have to say, as a physician making these decisions, these are really important, because I talk about CLL being a chess game. That first move is going to determine your second, third, and fourth move. And
Right.
odds are you're going to have more than one move in your CLL life. It's very rare that you do one treatment and that's it, one and done. That happens for
Right.
some of us. So how do you tell me about that conversation with the patient in front of you?
So I think the last speakers, I think, set me up nicely. Were being your own advocate. I really consider part of the job of the physician is to help the patient become their own advocate. So, as I like to say, really, with rare exception, nobody should be surprised when that time comes that they need to be treated. So it's really a progressive discussion over a long period of time, oftentimes, where we're talking about what are the reasons for treatment. Because, as was alluded to earlier, somebody who has an elevated white count, that's your thermometer, for lack of a better term, and that's the thing that people kind of focus on. But there's so much more. So, as not to belabor what was already discussed, so the indications for treatment, the patient should know that going in. So never be a surprise. And I tell them, you will come to me and you will know when it's time. Oftentimes my patients will say to me, it's for all the things we've talked about, it's time. And then we look upon some different markers. When it comes time to treating, Dr. Jacobs talked about some of the molecular markers that we do, and we do undertake that. And that really helps lead us in a direction for how we're going to treat. And I'll get into that probably as we talk. For me, it's really, really important, not only because of my personal journey, but because of my experience seeing these patients, and not just CLL patients over time, but really anybody with cancer, is what are their goals? That is really important. People are all at different places in their lives. Um, Not to be personal again, but my dad has cancer now, has a different type of blood cancer, and having those discussions with the and understanding what their personal goals are vital to determining what treatment you want to undertake. And really, when I say that, does the patient want to? Are they okay with taking a pill every day for the copy, or do they want to treat and then put it behind them? There's a lot of people. I think going back to the comment about watchful waiting that we had earlier. Um, you know, um, we watch and the patient waits. Same thing with treatment. If they're going along, some people want to put it in their rearview mirror for a while and be treated, and then have the time when they're not treated. And we have those discussions. We really look into what's their overall health. Are they older and frail? Um, are they young and vibrant? Are they old and vibrant? And I was joking with my wife last night. I'm 57, and I'm really right on the cusp of being considered elderly by a lot of these criteria. And I would say the people I play hockey with would tell you I'm anything but old. So I think we have to look at people as to where they are at their point in their lives, and really what their goals are. And then finally, what medications is the person on, and what side effects or what other issues do they have that we would be concerned about? Do they have liver disease? Do they have abnormal rhythms? Probably most people have heard of atrial fibrillation, which is an abnormal rhythm. Are they prone to bleeding? Are they on a blood thinner? Those types of things. And I use those as kind of the bedrock for how we're going to decide then how we're going to go about treating. But really, I think the key part for every provider, every physician, every person being treated, and every family member is to be that advocate and to know kind of what your goals are going forward. I really rely on that. And I'll just end that question with, now, oftentimes I'll have a person and I say, well, what are your goals of therapy? And they'll say, well, you're the doctor. And then we kind of unravel it a little bit more about what I mean by that. And really, I want to know what their goals are. How are they doing overall? How are they coping with the disease? Are they able to do the things they want to do? And what are their 1, 3, 5 year personal goals? I really try to get into that because that helps me really understand where they're headed.
Yeah, and I totally agree. I think having an involved patient is critical in all the studies in every disease, whether it's cancer or diabetes or hypertension or heart disease, suggest when the patient's involved in those decisions, those are shared decisions, the outcomes are always better. Let me
Yeah.
get you
And one
into
thing I try
some
to
of the,
do,
go ahead.
I was just going to add one of the things I try to do. There's a ton of data now around physical therapy. We call it prehabilitation. So I'm really relying on that. We know that patients that do physical therapy are more apt to actually to complete their treatment and actually thrive. There's a 7% improvement in overall survival in cancer patients in general, for those who are healthy. And Dr. K alluded to it in his discussion. But really, why I have that time up front, I want people to thrive. I want them to be more fit. I want to make sure they're eating properly. I want them to make sure they're staying physically active, because as we start down that treatment path, we're in a far better position if we start there than if we let them degrade over time. So that's something that I really try to utilize heading into the formal therapeutic treatment.
I'm going to narrow in on some specific treatments, and I know there's some controversy. In my mind, there's no controversy, but I'm going to put you on the spot here, Joe.
Okay.
Chemoimmunotherapy. Do you see any role for that
Mhm.
at all in a patient in front of you?
I would say that there's probably two scenarios. To me, I rely on the molecular targeted therapies invariably, but there are probably two instances, and I think the data shows this, that for people that are mutated, and Dr. Jacobs talked about that a bit for IGVH, and those that have are not do not have 17p deletion or TP53 mutation, those people, younger people, could do better. There's probably a small subgroup of people that may actually have a better outcome with FCR in younger people. The second group I would say is, as we're going along, for people who who really, again, going back into what their goals of therapy are and where they health wise, since I use the why we chose therapy as one of the barometers for how we're doing with therapy. There's some people at a point in their life that are particularly older who may benefit from a chlorambucil obinutuzumab, something on those lines. But typically, that's I think all the other data points towards the targeted therapies.
So I would agree with you, and I think it's very limited. Um, the role of chemoimmunotherapy extraordinarily
Mhm.
limited. But so we're now on targeted therapies, and we have fabulous choices. And one of the big decisions people now are looking at is continuous versus limited duration. So
Mhm.
how do you go about in that discussion, and if with a patient in front of you?
Well, I think that at the start, I tell them there's really no accepted standard first line. I think they're all really amazing choices compared to where we've come from. So I really base it off of, again, going back to where the patient's at. There's a lot of data. If it's somebody older, there's a lot of data in ibrutinib as a single agent. I think looking at adding a monoclonal antibody, um, it shows benefits. It's a deeper response in some younger people
Uh,
using
I'm gonna
venetoclax and
I'm gonna
obinutuzumab.
I'm gonna stop you for a
Right.
second there and just remind us what a
Mhm.
monoclonal antibody is.
Yeah. Yeah. I'm
Just
sorry.
remind us what a
Um,
mono.
yeah. So there's certain proteins on the surface of cells, and these antibodies are similar. If you get a flu shot, the flu shot builds antibodies against the flu. These are we make these in the lab, and they produce these massively, and they we can actually infuse them into people, and they actually target the cancer cells by targeting specific markers on the cells.
And that would be rituximab is probably the best known in CLL, but
Right.
obinutuzumab or the brand
Hmm.
Gazyva is the other. Ofatuzumab
Right.
is less used.
Hmm. Right.
Alemtuzumab is hardly used at all now, but there's several of these and
Right.
more in development. Yeah.
Right. Right. So again, with the venetoclax, which targets a specific protein called BCL2, um, that combination is, I think, there's a lot of merit for people. That's a year's worth of treatment, and you're done. Whereas ibrutinib, you're using until either they progress or the side effects are such that they can't or they don't want to go on further. And I think those are important discussions to have. A lot of it comes down to the individual's sense of their convenience and how they want to approach that. We don't have enough data to have one rise above the other. Um, I think that that's obviously as we go along. I really look at treatment now, and I have this honest discussion. And this is not scientifically based. This is experientially based. That um, I told you my personal experience and then my professional experience. I look at when we talk about survivability and where we're going to be in 5 years, we don't know what that next treatment's going to be in 5 years. When you think back to so many people that we know their journey, they were told one thing and a drug comes out 2 weeks later and they're in a different journey. And I think those are important pieces as we look at that. So I really try to have that discussion, explain that the response rates are phenomenal in all the combinations and in single agent, and that it really comes down to, do you want to have continuous treatment or do you want to be treated and stop? And there are people who do say to me, yeah, I'm okay taking a pill every day, because people do that all the time for blood pressure, for they do all kinds of things, as you know better than I. So I think that's how I approach that.
And I would add to that as a patient who was on ibrutinib in a phase 1 trial, as you know it, through Ohio State with Dr. Bird, and I think you were at
Hmm.
Ohio State then at that
I
time.
was.
Uh,
Hmm.
yeah, PCI through 2765. When Dr. Bird said to me, "Well, it's time to stop this. You don't have any disease." It was like, but it's my baby. It's my security blanket. So I think there are
Yeah.
people like myself who said, I feel so much safer taking this. I knew it was the right thing to do, but psychologically it was difficult. Uh,
Right.
uh, uh, Thank you so much, Dr. Flynn. We're going to hold on this and we're
Thank
going to
you.
switch over, but stay around because we're going to use your knowledge in our Q&A, and we're
Okay.
going to talk to Dr. Anthony Mato. And Dr. Mato has done so much research in so many areas, but his primary focus is the patient in front of him, bringing excellent care with his team at Memorial Sloan Kettering in New York City, New York. He's the director of the CLL program there. And among the many areas of research, he's been involved in trials that are re-examining how we measure response to treatment, and perhaps in the future may ultimately determine how we best individualize care. So, uh, Dr. Mado, I'm going to ask you just a little bit of a framework for us and tell us how things are shifting. What are the traditional ways that people respond? If you could explain to us a little bit about how remissions are measured, and both in clinic and in a trial, and then how that's shifting. I'll just let you go with that and give you that kind of broad question in terms of how things are changing. Thanks very much, Anthony.
Hi, Brian. Really great to be here. Thanks so much for organizing this conference through the CLL Society. It is true that the way that we're measuring response to therapies is changing fairly significantly and rapidly. The traditional response criteria were outlined by a group called the International Workshop on CLL, the IWCLL, and there are several categories that we think about. First and foremost, people always want to know if they're a responder, and there's a few different categories: complete remission or partial remission. Complete remission is what it sounds like, using fairly standard approaches like physical examination, blood work, assessment of symptoms, bone marrow biopsy, and review of a peripheral smear. There's no evidence of detectable CLL. That does not involve any special techniques or technologies to look for deep remissions. You look under the microscope, you don't see CLL, you don't feel CLL, you can't image CLL, you're in remission. Partial remission is just what it sounds like. More than approximately half the CLL has gone away on the bone marrow, on the scans, and the blood. And so less than that is actually not considered a responder. And there's another category called stable disease. Things could be somewhat better, but they're not to the point where we would say they're at least partially better. And then finally, there's progression of disease. And so these are the broad categories that have been used in almost all clinical trials to look for assessment, to look for depth of remission. You can imagine that something you alluded to, the difference between clinical practice and clinical trials is, in practice, we're not getting CAT scans as often. We're not getting bone marrow biopsies hardly at all. And there are subtle differences between a complete and a partial remission, particularly on imaging, that really don't make a whole lot of sense when you start to think about how patients do in terms of the outcomes that we care about, how long they stay in remission, how durable those remissions are. And so technology is shifting a lot towards using either flow cytometry or next generation sequencing to look at different parts of the CLL, either the blood or the bone marrow, or even in the future, the lymph nodes, to look for very deep remissions, either 1 in 10,000 cells, 1 in 100,000 cells, 1 in a million cells. And this approach is called
Dr.
minimal residual
Mado,
disease. Yeah.
Dr. Mado, yeah, I'm going to ask you when you go through this. We've discussed flow cytometry, so I think people, that's part of their nomenclature now. They've got that word, but next generation sequencing (NGS) is a buzzword that a lot of people have heard. But in your discussion, can you explain what that is and
Sure.
how that's revolutionized cancer care? Yeah.
The best way to think about any of these approaches, be it flow cytometry or sequencing, is that you're using a technology to identify a fingerprint of the disease that's distinct from the normal cells, normal lymphocytes, for example. With flow cytometry, you're looking at cell surface markers. With sequencing techniques, you're actually looking at the sequencing of the DNA to look for particular patterns that are unique in those cells. Typically, they're sequencing of the B cell receptor. And so I don't think it's as important, honestly, to understand so much the methodology, is to know that each of the techniques about the cells that allows you to follow them over time. And some are more or less sensitive than one another. Flow cytometry probably lets us get to 1 in 10,000 cells, maybe 1 in 100,000 cells. Next gen sequencing lets us get to 1 in a million cells in terms of depth of remission. And what we're finding more and more is that these approaches probably are more objective, more accurate, and more helpful in distinguishing response than me feeling your physical lymph nodes or spleen, or doing a bone marrow biopsy and looking under the microscope with my eyes to count 100 cells to see how many CLL cells are present. So we're kind of moving beyond the traditional response criteria. And the proof is in the pudding. A partial responder by the traditional criteria who's MRD undetectable probably does as well as somebody who's a complete responder who's MRD undetectable. So it kind of levels the playing field. And I really believe that in the future, we will see clinical trials that completely omit the traditional response criteria and shift more to these technologies to measure for depth of remission.
All right. So MRD, this is minimal or measurable residual disease. And I wanted to ask you a couple questions about this that come up a lot. When do you consider this test? Let's say, I know that certain trials are built around that. So maybe let's start with the trials because there it's a little more accepted. Tell us a little bit about some of the trial work that you're doing is using MRD as a decision point, and some of your colleagues around the world are using MRD as deciding about what to do and how to manage the patient. Can you explain that a little to us?
Sure. I'll first start by saying that I think a major limitation of almost all the trials that have been conducted with the novel agents is that there's no opportunity for making a decision based on these types of techniques. And so, for example, if you received a fixed duration of venetoclax with rituximab or obinutuzumab, we know at the end of therapy, if you're detectable, you have a more likely chance of progressing than if you're undetectable. But there's really not been a lot of not a lot of literature yet, and certainly no approvals to make a decision based on that positive result. Like, should I do something else in order to avoid that progression? What we're doing at Sloan Kettering and colleagues are doing at other centers is that we're trying to tweak the standard of care type approaches, the one size fits all cookie cutter, 12-month or 24 months worth of therapy, and make decisions based on depth of remission. So, for example, we have a trial, and this is just one example, called the Veneto Stop trial, which allows us to look at all of our patients who are receiving venetoclax based therapy and discontinue therapy, not based on some arbitrary time point, but really based on how deep the remission is at individual time points, 6 months or 12 months or 18 months or 24 months. It probably allows some patients to get off early and some patients who may potentially benefit from prolonged therapy to not come off at that time point as dictated by the current standard of care. We also have trials where we're adding therapies to patients who are MRD detectable at a certain time point to try to deepen that remission. So I think the future really will be clinical decision making based on MRD status, either stopping early or potentially adding additional therapies to try to improve outcomes for patients.
And this is an important point to me, and I'd like to see the language changed around this because the language talks about fixed duration versus continuous, and I think it should be limited duration. And rather than arbitrarily saying 12 or 18 or 24 months, you look at the patient in front of you, you look at their depth of response, and you make a decision then. Is that the direction the science is
Totally.
pushing us?
Yep. I completely agree with you. I think that anyone who's a specialist in CLL is not interested in a one size fits all approach. We're trying to tailor the regimens based on our individual patients, their disease biology, their needs, their comorbidities. The art here, when we're looking at therapies that right now are probably not given with curative approaches, is to give somebody as much as they need to get a good outcome, but also to not overtreat somebody to expose them to potential risk of toxicities. I think this is particularly relevant in a time where we're facing a pandemic, where we want to have patients who have the best outcomes, but not necessarily have as much exposure to the healthcare system. So I completely agree with you. I think the future is much more of tailor-made approaches based on patient comorbidities and patient disease biology and response.
And we even know from old chemoimmunotherapy data when we were using FCR, it was the depth of the remission, not how many cycles you had. If you got to a complete response after 4 cycles, you did as well as somebody who got to a complete response after 6 cycles. So even we have even older data with all other types of therapy. It's the depth of remission that really matters. So I'm
But
totally
of course,
with you.
we learned that with FCR retrospectively. The intent of those
Right.
trials was everybody at 6 cycles. They just happen to have some people come off a little bit early, like after 3 cycles or 4 cycles, who happen to be MRD undetectable. And later we learned their outcomes were the same. There's still no really prospective data, even with chemoimmunotherapy, that provides guidance in terms of decision making. All of that data about MRD is retrospective data.
Interesting. So practical question from a patient's point of view. Can you get everything you need from a blood draw, or do I need to have a bone marrow biopsy to see what my MRD status is?
that that's also not a one size fits all answer. I think the wind is blowing towards blood is probably good enough. The reason I say that is early when MRD was being particularly utilized by flow cytometry in patients who got chemo and antibody therapy, there was some discordance that was noted between the blood and the bone marrow, meaning more patients were positive in the blood than the bone marrow if they were checked at the same time. The more recent data from the novel agent based studies, particularly venetoclax, suggests that there's more concordance than we thought before. And that when you start looking at MRD like 12 months out or 24 months, they're close enough that I'm a huge proponent, not only in practice, but also from a perspective of clinical trial design, that we should be looking for MRD in the blood and not the marrow. I think marrows are sometimes necessary, but not a huge fan of doing marrows unnecessary.
Let me push on this issue, which I think is very important, is the name, measurable or minimal residual disease. That does not mean that our CLL is eradicated. It does not mean that we're cured, that it's never coming back again. Can you talk a little bit about that language, and also maybe give us some sense of how some patients do who don't reach MRD, but some people seem to have a good prognosis with that.
So you're right. In a way, it's a meaningless term because the term measurable or minimal depends on the compartment you're looking at, the technology that you used. And so, for example, I could have a patient who's undetectable by flow cytometry, who at the same time is detectable by next-gen sequencing, and yet we're applying the same term to both situations. Probably what we should be saying is detectable or undetectable, and at what sensitivity. So, for example, you are undetectable at a sensitivity of 10 to the minus fourth, or 1 in 10,000 cells, but you're detectable at a sensitivity of 10 to the minus 6, or 1 in a million cells. I think that's much more informative to providers and to patients. For patients who are so I think it's really important, and we said this during the MRD session that we did a few months ago, is that MRD does not necessarily have to be the goal of all CLL-directed therapies. And the BTK inhibitors are a great example of therapies that are incredibly active, well-tolerated, continuous, and people can be on them, like 75% of people can be on them for 5 or 7 years, and yet there's hardly a patient who becomes MRD undetectable. And so really that approach is limited to venetoclax-based therapy and chemo immunotherapy combinations, and not the BTK inhibitors. So if you're on ibrutinib and you're listening to this, or you're on acalabrutinib and you ask your doctor, are my MRD undetectable? And they say no, they know they don't even need to do the test to know that, yet you can still have an excellent outcome and you're receiving that therapy. So it's not a requirement for all of our approaches, and that should definitely be one of the most important points to come out of this session.
Yeah, and I appreciate you making that loud and clear, because people sometimes get upset or depressed because they're not undetectable MRD, and that may be clinically completely insignificant. Um, can you touch a little bit about MRD moving into the clinic, and out of the lab, out of the clinical trials, I should say? Do you see it being used more in the community, and do you think it's ready for it to be used now?
So I think it is ready, that's for sure, especially as we have more approaches like the clonoSEQ adaptive approach, which is a next-gen sequencing, which is very easily adoptable by any practitioner. I think that it will be incorporated into the clinic as clinical trials are reported that are using MRD based approaches. What I think is the biggest hurdle is actually having drugs labeled based on MRD. So, meaning if I'm a physician and I see excellent data for making decisions about venetoclax based on MRD, I guess it's my right to discuss that with the patient, and we might change the way that we're administering the therapy. In order for venetoclax to have an approved label to be MRD driven, that requires regulatory bodies like the EMA and the FDA to say it's okay to use those types of endpoints. And while they're getting closer and closer to doing that, it hasn't yet happened in CLL or other cancers, as far as my knowledge. And so there's different levels of use in the clinic. An expert might feel comfortable doing it already, whereas somebody in practice might be waiting for regulatory bodies to say that it's an acceptable approach.
All right. And just quickly in 30 seconds, if you had experience with having this paid for by your patients outside of a clinical trial.
Um, so we do this in our routine practice on some level, and I what I could say is I haven't had patients come to me directly with a bill saying their insurance wouldn't pay for it. And so my general experience is that it has been paid for, covered by in all networks. I don't know. I haven't had much of an issue with it personally.
All right. Well, Dr. Mato, thanks very much. And we're going to move on to Q&A, and we'll have Dr. Flynn and you, and we've got a ton of questions, and I'm going to throw them out. I'm going to continue first with you, Anthony, and that is talk to us a little bit, and we didn't get a chance to get into this in any depth, about eradicating disease and MRD, because we both have seen patients who've gotten to undetectable MRD by the best technologies we've had who've relapsed. So explain why MRD, and I know you've gone over this, but I think it's worth repeating, is not necessarily an eradication of the disease. And is it sometimes an eradication of the disease? It's gone. Help me understand that point, because that's what we're all aiming for, is no more CLL. It's gone. Yeah.
It's a good question. Uh, Undetectable doesn't mean that it isn't necessarily not there, and each technology has a limit. With a pair of binoculars, you can see a certain distance further than with versus with a telescope. And I think that yet, depending on the technology that you use, it's possible that although there's not one cell in a million, there might be 1 in 10 million that may come back in the future that technology couldn't detect. And so I think it's probably a necessary prerequisite for curing patients of their disease, but it doesn't mean that just based on whatever technology I use that says no CLL detected, that there isn't CLL somewhere beyond that at a deeper level. So but of course, the better and better the technology gets, the more we will be able to say with certainty that there's no CLL present.
All right.
I don't know if I answered that, but
Dr. Yeah, no, I think that's good. Thank you. Dr. Flynn, there's a couple questions that are not exactly related to treatment, but that's on the testing, and Dr. Jacobs covered the tests that he likes to do, the FISH, the mutation status, and the TP53. Um,
Mhm.
we teach at the CLL Society it's important to have those tests again if they haven't been done recently before treatment. Can you talk to us a little about clonal evolution and what that means and why you have to test again, even if somebody's had no treatment, how their CLL may evolve? And not all tests need to be repeated, but if you could
Sure.
kind of walk us through that,
Right.
right?
So the idea when you start off that your CLL is just one disease, it really isn't. It's you have different populations of cells, and I think this speaks to what Dr. Maida was talking about of the measurable residual disease. You're going to have the potential to have cells remaining, and as you do, those cells. I'm going to make it the simplest way that I look at it, in this terms of those cells that you kill, that you're able to eradicate fully, the are gone. And if you're able to wipe out certain populations that Dr. Jacobs talked about, that you are potentially selecting out the more aggressive clone or more aggressive residual disease, and those grow over time. And I think that, to me, as I look at CLL and long-term responses and how do we look at the disease, that's part of the issue. You're actually singling out the more resistant disease as you go forward. And we as oncologists, and really in medicine in general, we still try to apply our oldest terms for remission and cure, which is really a solid tumor delineation. But CLL, because it's such a slow growing or indolent process, that you do single out these different cells as you go forward, and those end up being the ones that remain, and you have growth of those cells. That's kind of looking without getting too molecular about it.
Right. And that evolution can happen even without, what I call the Darwinian pressure of therapy. People, CLL can clonally evolve even before they've had any treatment. They may have had one set of markers at the time of diagnosis, and when they need treatment 3 years later, those markers may have changed, except for their mutation status, which generally stays
Right,
stable for the whole course of your
right,
CLL. And
right.
and and it, and they never tell me, I mean, if I'm just being a pessimist, they never change for the better. They just get worse. Am I wrong on that? I mean, people don't have 11q and then lose it, or have 17p and then lose it. They may have the disease knocked back to a level where you can't measure it anymore after treatment, but they don't.
Yeah.
Generally, your CLL gets worse clonally over time. Is that a fair statement to say? Sadly.
Yeah, and I think just thinking of it in two ways. One is as you treat the population of cells, those that are going to be most likely to die from your treatment are going to be gone, and the ones that are more aggressive or that remain are going to grow. And even those that, when you're not being treated, those that divide at a different pace or act differently, more aggressively, are going to. So your quote unquote good CLL cells may remain in a similar amount, but they're surpassed by the more aggressive ones.
Dr. Mato, one of the drugs that's revolutionized the care of CLL is ibrutinib. A lot of people, like you say, can take it for years and years, but intolerance becomes an issue after a while. And What about reducing the dose? If you have less of the CLL around, can you get by with a lower dose? Can you talk to us about that
Sure.
that decision, or do you sometimes switch to a different BTK inhibitor? How do you have that discussion with the patient?
Intolerance is an issue, definitely most closely associated with ibrutinib. I would say most closely associated with the PI3K inhibitors, but that's not even part of the conversation. But with ibrutinib, you probably have about 10 to 20% of patients over time coming off because of a side effect, and we can kind of list what those are. Um, what I would strongly advise not doing is starting the dose at a lower dose just because, or lowering the dose just because you've reduced some of the disease burden. There's retrospective data and a tiny bit of prospective data to say that that's okay, but I don't think that straying from the label in terms of initial dosing decision makes a whole lot of sense. What I do think is reassuring is that if you have to lower the dose because of an adverse event, meaning the FDA actually gives guidance in the label on how and when you should do that, that the outcomes are probably not compromised. So for physicians out there who are pushing patients to start at a lower dose, I don't think it's the best idea. Not because it may or may not work, but it's not really been tested. If you have to lower the dose, it's okay. And whether you can switch to another BTK inhibitor like acalabrutinib and get away with it from an adverse event perspective, there is some data that suggests yes, but there are some adverse events that may occur on ibrutinib. Like if I had a patient have a life-threatening bleeding event, I probably wouldn't feel comfortable switching to another BTK inhibitor. If I had a patient have an unstable, life-threatening cardiac arrhythmia, I probably would not do that. If I had somebody with a rash or some joint or muscle aches, I might try another one to see if that wasn't reproduced. So I don't think that you can just make the blanket statement it's okay to switch from one to the other.
Thank you for that. Dr. Flynn, kind of a step back and a pretty basic question. Remind us what chemotherapy is and what chemoimmunotherapy is, just and how that's different from targeted therapy.
Right. So chemotherapy is those drugs, cytotoxic. They kill all cells that are growing. They basically, if you think back to your basic biology in high school many years ago, it's as your cell has a different, they're in different phases of growth on any given moment. And the chemotherapy typically goes cells that are dividing, and that's whether it's a solid tumor. Chemo, when we talked about monoclonal antibodies and things that are really working approach to the disease. So it's actually binding and causing the cells to die by targeting specific aspects of the cell. And that was the older way. and now we have these molecular targeted agents.
Uh, uh, Dr. Mato, with the ability to test and to measure very low levels of disease, we can find out that people are beginning to relapse before they're symptomatic. Uh, does this start to suggest that, hey, maybe there's a low level of disease, let's kick it while it's down? Or do we wait for those same criteria that Dr. Jacobs went over until the patient is, we see doubling times, or the patient is symptomatic and having, CLL that's interfering with the quality of their life? Is this an active area of research, and what are your thoughts on this area?
Absolutely an active area of research, and I think that it's a very reasonable approach to consider, given that, as you mentioned earlier, CLL is a disease where the genetic material is not so stable. When there's not a lot of pressure to kill it off, the clone can mutate or evolve over time. So I think that an important research question is addressing what we call molecular or MRD positive relapses for patients before they have a full blown progression. If you look at the criteria per the IWCLL, right now the standard of care is to wait for traditional progression that warrants an intervention or has a symptom. So there are studies that are looking at this particular question. Rarely in our practice do we think about doing such a thing, but it is not the absolute standard of care for all patients.
All right.
And I
Uh,
think it
and
speaks to why it's important
go ahead.
that people are they consider clinical trials, being part of a clinical trial, being part of a registry. That's why we are where we are today, is because all those people before had gone through clinical trials and helped us.
I totally, I totally agree with that statement 100%. I don't in our practice, we don't. It's not that everyone has to go on a clinical trial, but I always feel like we should at least have a clinical trial option for every patient to consider.
So here's a question that I bet you've been asked more than once, and I'd like both of your answers on this. It comes up at almost all our meetings. Any counsel you give your patients on the use of medical marijuana in terms of managing their CLL? You want to start with that, Joe?
Sure. I want to make it depends on the state you're in. So I'll start off with that. I think that matters. I think that going if you're looking at there's so much about the treatment of the disease is around the symptoms that I think help impact on their symptoms to improve their quality of life. So I actually, if they against it in any way, shape, or form.
Yeah,
Anthony,
I
you
would
want
give
to
a
add
little.
anything to that?
I would give a little bit of a
Go ahead.
different take. For me, I try to be data driven. Um, for example, the data behind green tea and CLL is one that I don't really think supports its use at this time. The same for medical marijuana. I haven't seen any literature to really tell me that it improves any particular symptom or feature of the disease for patients. And depending on the way that it's being taken in, a lot of these drugs have potential to damage the lung. I'm not a proponent of having anything on board that might also propagate adverse event related to a drug. So I'm a fan of anything as long as there's a strong level of evidence to support it. In the absence, it's not part of our routine recommendations in our practice, regardless of state.
There's no data showing that it is used in CLL, but there are symptoms that people have that there's data that it can actually benefit. That's what I was trying to allude.
Yeah. So
As support.
let's talk. Yeah, and I would agree. I think as an adjuvant therapy to, for people having, symptomatic loss of appetite or nausea or things like this, it can be helpful. Uh, let's talk about some other options. You talked about that clinical trials always being an option. And I'll throw out something that one of the questions that I've got in front of me, the oral medications, Loxo 305, ARQ 531, and CG 806. Are those currently available in clinical trials? Can you give us any advice on those? I'll let either one of you answer if you have any thoughts. Can they be obtained by patients? by compassionate use if they need them? Are they only through clinical trials? Help us understand that.
I can answer
Either
that
one of you.
question. So
Yeah.
the three molecules that are referenced, the LOXO 305, the ARQ molecule, and the CG806, they're all non-covalent BTK inhibitors that are being studied in clinical trials at this time. None of them are approved. The promise of these molecules really lies in their mechanism of action, and that they have the potential to overcome the most common reason why BTK inhibitors like ibrutinib fail, is the development of mutations in the BTK molecule itself. There has been very early data published so far that appear to be very promising, but certainly we're waiting for larger data sets and more data from clinical trials to decide whether or not they fit into routine clinical practice for patients. At our center, we're studying the LOXO 305 and the CG806 molecule. The other molecule, the RQ molecule, is also being studied at other centers in clinical trials. There are rare instances where patients can get compassionate use of them in an individual basis, meaning the physician would have to write a protocol just for that patient. But my general take is the trial criteria are so broad that most patients are eligible for these trials if they need to be. But certainly none are prescribable in practice at this time.
And Joe, let me push you on the venetoclax issue. Are there we have all these BTK inhibitors, reversible, irreversible, that bind differently. What about with venetoclax? We seem to know less about why people are resistant to that, though that's changing. And are there second generation venetoclax-like drugs coming along?
So we're starting to learn more about the mutation development for patients treated with venetoclax, and I think that's similar to ibrutinib. It's really remarkable how rapidly we've discovered some of these issues, and as we're looking for other BCL2 inhibitors, those are ongoing. I think that it's combination with oncology is a funny thing where they target slightly different, similar to the face together, which is a common thing that we've done. I think that the overarching around there's going to be so many different aspects of how do we do that. So specifically, yes, we've learned about some new mutations that we found.
All right. So we have 1 minute left, and I just one technical issue that people have asked, and maybe this is my fault for throwing around the term mutated versus unmutated in IGHV or IGVH. Can you, Anthony, explain that again about mutated versus unmutated? And also, I've seen both IGHV and IGVH. Can you just, in just a few seconds, kind of explain what that's all about?
I think that I think the term is the IGHV and IGVH, so I wouldn't really dissect that too far. Um, the best way to think about that is how mature the CLL cell is. More mature means mutated. Less mature in terms of the development of the receptor on the surface means unmutated. The more mature cell tends to behave a little bit better, slightly less aggressive in its clinical course, which is why we say mutated IGHV CLL is considered a favorable prognostic factor.
All right. Well, I'm going to thank you both. I sure learned a lot. Our deeper dive is continued, and we've gotten through first treatment and how to measure it and how that science is rapidly changing. And I so appreciate your time and your expertise in the research that you're both doing in CLL, and I look forward to working together. And if you're interested in MRD specifically, Dr. Mato did an amazing webinar that we have archived on the website that's really worth capturing. And if you're interested in the early management of CLL, Dr. K did one on that, which is archived and again, really worth capturing. So thank you very much, Dr. Flynn, Dr. Mato.